Aloha, welcome to Healthcare in Hawaii. I'm your host, Josh Green, family practitioner, ER physician, senator from the Big Island of Hawaii. Over the last several months, we've engaged in a very vibrant discussion about healthcare in our state. We've talked about healthcare reform, the Affordable Care Act, our healthcare shortage, specifically the shortage of physicians. Kelly Withy came and spoke to us about that quite eloquently. We've had time with some of the administrators, the insurance companies, people at JABSOM, our medical school, experts in many fields. But today I feel very privileged to have a friend and colleague, a physician here on my program, Dr. Stephen Kemble, who was educated at Reed College over on the mainland in the late 60s. It's an extraordinary undergraduate institution where he got his degree before going to medical school, first at UH and then over at Harvard. We have experience from him in our program also for internal medicine. Stephen then returned to Cambridge to study psychiatry. He spent several years there running programs for them before returning here home in 1985. He's been a very important piece of our healthcare system because he's compassionate. He cares for people at the Queen Emma Clinic dating way back to 1989. Now he works with Queens, and he's a thought leader here in the state of Hawaii. I wanted to have Stephen join our program because today we're calling it Healthcare Reform, Truth or Dare. We've spoken so many times about things like the Patient-Centered Medical Home, the Affordable Care Act, the Triple Aim, all of these large concepts, but the question I had, and I'm going to ask Stephen to really elaborate on this, does it all work? What's the answer for healthcare in our state? So Stephen, thank you for joining me.
Thank you.
Good to see you. So first, tell me a little bit more about yourself and what you are as a provider so our viewers can know more about you.
Well, I trained in both internal medicine and psychiatry, but I've been practicing as a psychiatrist here since '85. But I've always done something on the psychiatry general medicine interface, and that's my Queen Emma Clinic job, where I'm helping train internal medicine residents on dealing with psychiatric issues in primary care.
Right.
I also have a long-standing interest in health policy and healthcare reform. I've had an informal discussion group with several friends. We all go surfing on Sunday morning and then to Starbucks afterwards and talk about healthcare reform. And it's been a back and forth. It includes myself as I'm a single payer advocate, and another one of my friends is a conservative Republican. And we've had this ongoing dialogue for 18 years now.
Incredible.
On healthcare reform. And so I've done a lot of research for those discussions, and then I got involved with health policy issues here in the last few years.
See, one of the things I really like about you and why I think our viewers should appreciate this program that we have today is because you're one of the individuals who both has very expansive views of healthcare reform and what it should look like and what the system would be at its best. But you're also a practitioner, and you really see it in the trench. So you see these issues when we have individuals with severe mental illness, which I think that George Green was on our program once talking about how that's the largest category of preventable hospitalizations in our state.
Yep.
Things like that drive costs, which you are actually taking care of, and then you translate it into big ideas. Is that a fair statement?
That's a fair statement.
Okay, so that's why we have you here today. Why don't we dive right in?
Okay.
So the Affordable Care Act, passed several years ago now. Was it a good move? Do you think it was the right thing to do?
Well, the Affordable Care Act was focused on expanding health insurance coverage, and it was written by people from the health insurance industry. And there are some good things in it, like the Medicaid expansion, like eliminating pre-existing condition exclusions, which we already didn't have here in Hawaii thanks to our Prepaid Health Care Act.
Right.
But there were some good things about it, but it was organized around the health insurance industry, which is the bulk of the problem of why our system is so astronomically expensive and so ineffective, is because it's written by and organized by insurance companies rather than by those providing care for patients.
So I've heard you speak in many venues,
Yeah.
but you've said that one of the big challenges nationally is the administrative cost of healthcare. Could you explain that a little bit more for our viewers, what it looks like nationally, how large a piece of the pie that is, and so on?
Well, there's a study over 10 years ago that calculated that about 31 cents out of every dollar spent in the U.S. goes to administrative costs. And other countries with universal systems, it's more like 5 to 15% range. So it's way higher. U.S. doctors spend about 3 or 4 times as much on administrative costs of dealing with insurance companies as doctors in, say, Canada. U.S. hospitals spend 3 or 4 times as much, or at least twice as much as hospitals do on administrative costs in other countries. So there are very large administrative costs here that do not apply in countries with universal systems.
And I think that that's important to mention because we've explored the overall budgets of healthcare in different parts of our discussions, and I've seen the number anywhere from 2.6 trillion to about $3 trillion of annual spend. So when you start talking about as much as 31 cents out of every dollar, we're talking now, you know, $1 trillion of expense that isn't, it appears, going to actual care. Is that correct?
And the 31 cents out of every dollar was 12 years ago. It's got to be higher than that now. It's probably 40 cents of every dollar now.
Because
it's been going up.
Because we're a local show, and I've also heard you talk about, like HMSA, for instance. It's my experience, and correct me if I'm wrong, they've tended, as compared to some of the mainland companies, they've tended to keep costs, relatively speaking, lower. Is that a fair statement?
Yes, I think that HMSA, I mean, doctors often object to some of the heavy-handed aspects of what HMSA has done at times, but they have generally been looking out for the good of the whole community, and they have kept some control over the fees and prices paid for health care, which is what would happen in a universal system. And up until relatively recently, it wasn't too difficult to deal with HMSA. I think they've been going down the wrong road in the last few years and making things much more difficult and complicated for doctors. But it used to be they were a pretty benign insurance company and kind of kept the lid on prices while making sure that everybody got the care that they needed. It used to work pretty well.
Yeah, because I've noticed, you know, I have kind of a, you know, an interesting relationship over these years with HMSA, and one thing that occurs to me is that HMSA almost approximates a single payer model in our state because they're so large, and then Kaiser has the other sliver. Right. So I don't know that we have to extrapolate our experiences here necessarily to the state, and I'm sorry, the national scene, but I just wanted to kind of get your feeling about that.
I think if we were to take the principles that make a universal healthcare system cost effective and have HMSA implement them,
yes,
they could do a lot of it just there because they have such a big market share.
Right.
But unfortunately, they're not going that direction right now.
Yeah, I think that there's an interesting tension in HMSA right now because my instinct tells me that the couple folks at the very top, Gold and Hilton Rathel and so on, they seem to be at least mindful of these questions and working towards some solutions. But there's an incredible tension there in the inner parts of that machine because there's a very natural tension, I think, between the whole world of healthcare administration and the physician community and the nurse practitioner and physician assistant community. They're trying to deliver the care. So, okay, so you've established with me that a large part of our healthcare system is administrative costs. Yeah. And let me just throw out a couple assumptions and see what your take is.
Okay.
So some people say there's just not enough money in America in the healthcare system to take care of everybody. What would you, as a provider and a thinker on healthcare reform, say to that? I have a three-point strategy to get to cost-effective healthcare. The first is you have to include everybody, cover everyone, because unless people have access to cost-effective care, usually in office settings or clinic settings, outpatient settings, yes,
their problems are not going to be dealt with effectively. They're going to end up in the emergency rooms and hospitals a lot more often than they would otherwise.
Okay.
So you have to assure access to outpatient care for everyone in order to keep the total cost of the system down. So that's one thing, is assure care for everyone.
Okay.
Two, simplify and streamline administration.
Mm-hmm.
You want to take all the complications you can out of it so that it becomes administratively simple for a doctor to take care of patients.
Right.
In other countries at the universal systems, the doctor swipes a card at the end of the visit, punches in the procedure code, and they get paid automatically 3 days later, and they don't have to hire billers and coders and all this kind of stuff that U.S. doctors have to hire.
Let me ask you a quick question about that. Okay, so, and we'll go over these one by one. So, fraud. You know, I could see people throwing that at the physician community and saying, how do we make sure that there's not too many swipes of that card or too many codes? Is it not really an issue?
You need to make physician pay as incentive neutral as possible.
Got it.
Right now, we have a fee-for-service system that has a lot of perverse incentives in it. It's skewed toward procedures at the expense of, cognitive services like taking a history and doing a physical exam.
Right.
So instead of fixing that, we're adding a new set of incentives to try to counteract those perverse incentives, and these new incentives are equally perverse. So we're adding layers of complication. We should just get the incentives out of it, make pay incentive neutral. I can think of 3 ways to do that. One is salaries. You pay doctors on salaries, so that they're paid to take care of a group of patients, and their pay doesn't depend on which thing they do. If they do a procedure or they talk to the patient, it's all included in their salary. That's one way to do it.
Yes.
Another way is to have a fee-for-time system, where instead of establishing a fee for a procedure based on how complicated or whatever it is, you base the fee on how long it takes to do it, how long it's scheduled in the operating room.
Which would essentially be salary because you'd be working most of the day.
Except that you get paid more if you work harder.
Okay.
And in salary, you don't. And fee for time, if you work harder, you get paid more. But you can detect fraud and abuse just by adding up the hours.
Sure.
Because that's the only thing that matters for getting paid.
Right.
The rest is neutral. You do what you think is best for the patient. And you don't worry about what procedure code you're going to use or what diagnosis code, because nobody's looking at that. They're just looking at the time schedule.
Got it. That which is a lawyer model in some ways, the billing, right?
Except I wouldn't do actual billable hours. I would attach a time to a procedure. Like if you have a patient that you know talks a lot and it's hard to get them to the point, you want to schedule them for a half an hour. That's what you book for, is a half an hour. And you get paid for a half hour. You might spill over that a little, but if you paid for the actual time billed like the lawyers, then you'd have an incentive to pad the time.
Yes.
So if you tie a time to the procedure and then you pay that, then if you're inefficient, you eat it rather than the system.
Okay.
So that would be fee for time. And the third system is capitation, where you pay, like if you paid primary care doctors, everyone needs a primary care doctor, so you could do this universally. Whatever patient is assigned to that primary care doctor, they get paid a flat monthly fee to be responsible for their primary care.
Right.
And if they take on a bigger panel, they get more money, and a smaller panel, they get less money. And I would probably cap it so they don't overextend themselves and cheat the system.
Yes.
But if you got paid by the patient, and then you're responsible for all their primary care, that too would be incentive neutral.
Right.
Whatever you did, you'd be paid the same, and you focus your efforts on what's best for the patient rather than worrying about the complications of how you're going to bill and code and get paid and things like that.
Okay.
So any of those systems could work.
And then you said there was a third thing. So you said you'd do 3 things. You'd cover everyone to assure access.
Okay.
You would simplify and streamline.
Okay. And the third one is you use the administrative savings that you've gained, which would be very substantial,
Yes.
to bring down the prices paid for health care.
Explain that to me.
If you take, let's say you pay a hospital with a global budget instead of fee-for-service. So they're giving their operating budget at the beginning of the year, and they just run their operations, and they don't have to bill at all.
Right.
That would take 20% of their costs right off the top. For doctors in practice, you could probably knock their overhead in half if they had any of these systems that were incentive neutral and they didn't have all the complexities of the billing and coding system.
I'm interested that you said that. One time, not long ago, about a year ago, I put together a small proposal for one of the insurers in the state.
Yeah.
And I said, look, do me a favor. Pick some physicians that you trust, that have a very clear track record of you're not concerned about them abusing the system. They do a good job. They have good outcomes, all these things. They never do extra tests. They don't prescribe medications that are out of the formulary or anything too costly. Take those physicians. Take away all of the administrative responsibilities that they have. And so at that, in one fell swoop, they usually have 6 or 8 people working for them. Allow all of that resource to be used for clinical expansion. All of that resource towards health education, extra time to see patients, extra time to do follow-ups, to make sure patients, took their medications properly. All of those things, because you trust this physician and their practice, there's no reason for half of the money that goes to them to be used to run their practice, because it was about half. And that hasn't caught on yet. But I'm wondering if that's not going to be a necessary move at some point.
I think that that's a more powerful idea than you may even realize, because I think that you could take your top 6 doctors that that would work with.
Right.
But if you set up that model, the other doctors would all want to do it too.
Right.
And if they were allowed to do it, they would be highly motivated to do a good job, because they wouldn't have to go back to all the complications they have to deal with now. So they would try really hard to take good care of their patients, keep them out of the emergency room, really out of the hospital. And instead of 6, now you've got 3/4 of the doctors in town who are practicing cost effectively with that kind of model. you need to empower doctors to do what they're trained to do, which is to manage the care of their patients.
I think that's a perfect place for us to take our first break.
Okay.
This is Josh Green with Healthcare in Hawaii. I'm joined by Dr. Stephen Kemble. Thanks for joining us.
Aloha, my name is Kenneth Lawson. I'm your host here at Life in the Law. I'm really interested in law as I practiced it for 18 years before coming to Hawaii. I practiced criminal law and civil rights law on the mainland. Now I teach law at the University of Hawaii Law School, William S. Richardson School of Law, and I bring in guests who are very current on legal issues that affect your life here in Hawaii. Come and join me every Wednesday at 1 p.m. as we explore how the law affects you, how the law is changing, and why it's important that you should care about what's going on in your community. See you then.
Aloha. Welcome back to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island, ER physician and family practitioner trained. Today I'm joined by Dr. Stephen Kemble, who did a lot of his training here and at Harvard. He is a well-regarded psychiatrist, and he's a thought leader here in the healthcare policy world. Stephen has come up with many different proposals and has done it in a very thoughtful way based on a full assessment of healthcare systems across the country. So, Stephen, thank you for joining us.
Thank you.
In our first 15 minutes, we were talking a little bit about the basics, about the Affordable Care Act, some things that you thought were decent, some of the things that you would have done to focus on a better healthcare system. Why don't we now talk a little bit about, let's talk about the triple aim for a second,
Okay.
because it gets thrown out all the time that that's what we should be working on as physicians to save this healthcare system. And I had Hauk on the show, Dr. Hauk, not too long ago, and he sang its praises. Why don't we get your take on the triple aim and see how we might make that actually work for our system?
Okay, the triple aims are 1, improved quality of care, 2, improved health of the population,
Yep.
and 3, reduce costs.
Right.
And I am in complete agreement with the triple aim. The triple aim was, the idea came up with by Don Berwick, who for a while was director of CMS.
Yes.
And he's been a leader in quality improvement for many, many years. I spent 15 years on the board of directors of the Mountain Pacific Quality Health Foundation doing quality improvement projects for Medicare, and Don Berwick was one of our heroes. So I completely believe in the triple aims.
Mm-hmm.
My concern is that the way we're trying to implement healthcare reform now is not going to get us there. In fact, I think it's going to take us farther away from them. So we're doing all these things in the name of triple aims.
Yes.
That there is no evidence that they're actually going to work to get us there. And I would like us to do things that have been shown to get us there rather than things that have been shown not to get us there.
Well, let me have you unpack that for me. So,
Yeah.
patient-centered medical home.
Yeah.
That's been talked about on the show a few
Yeah.
times. For those who might not have caught previous shows, patient-centered medical home is a model that's being used in different places in the country. In Hawaii, we're using it mostly at the behest of HMSA, and it allows for a few dollars per member per month to come to a physician to work on supposedly health education, better outcomes, and so on.
Care coordination.
Care coordination, right. Very, very well said. So there have been mixed results. Some people complain about it bitterly to me. Others accept it as part of the system. What's your take on patient-centered medical home?
Okay, I think that improving primary care is crucial to successful healthcare reform.
Okay.
We need more primary care doctors, and we need to make it easier for them to do what they're trained to do.
Got it.
So there's no question that we need primary care. And if by patient-centered medical home you mean making sure everyone's got a primary care doctor who has the ability to spend enough time with them so they know their patients and can manage that population,
Right.
I'm in complete support. I have no disagreement with that at all.
Got it.
However, we have confused and mixed the idea of a patient-centered home with the idea of pay for performance, where we're going to have primary care doctors have to do all these things having to do with how extensively they've computerized their practices, whether they use physician extenders, whether they have all these elements that are for certification at a level 3 primary patient-centered medical home.
Right.
Those kind of things are relevant for a small percentage of the population with complex needs. Most patients would do fine with a primary care doctor and an administrative assistant or a medical assistant.
Yes.
And a simplified administrative structure, and that's all they would need. And that would take care of 90% of patients. So we're spending all this money and trying to apply it to all of primary care instead of just the high-risk patients who could use that kind of thing.
Let me chime in there because I think that that's
Yeah.
very well said. You know, one observation is that for instance, in the Hawaii IPA, we did an assessment, and large group of doctors. Really, it does approximate the entire state because it's enough doctors, and we found that 3.6% of our patients in Medicaid, our Medicaid population, were consuming 61% of the resources. Yet, the patient-centered medical home program was applied to all of them, which I thought, well, look, in Hawaii, we now have, because of the expansion and the Affordable Care Act, we have about 360,000 Medicaid individuals. 3.6% of that is, you know, about 12 or 13,000 people. Now, that 12 or 13,000 people sounds like a group that we could really work harder on and manage, because it's consuming 61% of our time, healthcare spend, which is well over $1 billion. That's where we would have a great target. Instead, however, a lot of these programs are meant to deal with the whole 360,000. We can't get to it.
That's because they're designed by administrators, not by clinicians.
Okay. Yeah. So you're saying that you would take, if you were going to do patient-centered medical home or these pay-for-quality initiatives, you would focus it much more.
Right.
Okay.
I think that if you can take the administrative burdens off of primary care doctors generally.
Yes.
As I said, most primary care could be handled in the community, in the private sector.
Right.
Then you would use the community health centers or places like Queen Emma Clinic, have them be the complex patient-centered medical homes where you have all the physician extenders and the community outreach nurses and things like that, and send the high-risk patients there.
Yes.
And then you could target your resources where they're going to do some good instead of spreading it as a shotgun approach to everybody where most of whom don't need it.
Right, and that I think is it's a pretty serious concern, because I'm worried that when you spread the resources quite thin, number one, it's difficult to get the doctors interested in really doing it right. And two, you don't necessarily feel the effect. To have a few $1,000s extra in a practice doesn't mean you can hire an extra individual. It means that you can spend a couple extra hours on lots of people. Whereas if you had a lot of resource to focus on a clinic that was underfunded, or a group of people, for instance, that use the ER over and over and over again, you might see much better gains. Okay. So, so you would rather see, rather than patient-centered medical home as a part of the AAA, what would you rather replace it with?
Well, I would say support primary care, and target your extra resources for high-risk, complicated patients to where it will do some good.
Okay.
You know, that's basically the idea. If everyone has access to a primary care doctor who knows them and can spend enough time with them to deal with all their problems when they come in for a visit, that's the bottom line. That's what we need to get to. And instead of focusing on that, we're focusing on people from administrative or policy level, higher level, who are thinking in terms of business practices, designing things generically without regard for what it actually means when you look at it in the terms of care of individual patients out in the community.
So you would simplify the model very significantly then. You'd get rid of some of the administrative responsibility and perhaps burden would be a word to use here, and you would invest instead on increasing training, increasing actually the pool of primary care providers. I think I've heard you talk about the shortage as well. Do you see that in the kind of in the trenches? Do you see the shortage?
Oh, absolutely. In psychiatry, it's severe. There's not only a shortage of psychiatrists, there's almost none that are taking Medicaid anymore, and I blame that directly on Medicaid managed care, which our DHS has jumped on that bandwagon in stages starting in the 90s and the rest in 2009. They have made it much more administratively difficult to take care of Medicaid patients, to the point that in my practice in Queen Emma Clinic, I have 2 half-day clinics a week, and a significant part of my time at every clinic involves patients who are having problems with the system. They've gotten bumped off of their general assistants because they missed an appointment, even if I was on vacation. That somebody who's hired by DHS to evaluate their eligibility says, oh, you didn't have an appointment this month, so we're cutting you off for 2 months. Obviously, that puts them in crisis. They can end up homeless. They can end up suicidal. And I have one that's been in and out of the ER because she's suicidal because of exactly this. So I run into this all the time. I run into patients who can't get their prescriptions filled because their formulary has been narrowed down, and I'm running into prior authorizations for cheap generics now. Drugs that a few years ago cost $4 a month, I'm getting prior authorization requests for, and now they're being told that the price of the drug is $130 a month. I mean, there's crazy things going on, and in the Medicaid population, it's the worst, and you cannot run a practice when you're having to deal with these kind of hassles every other patient, which is what is happening now.
Right.
And the people that have hired the managed care companies don't want to hear about this. The managed care companies are telling the state that they're doing a great job saving the money, and those of us in the trenches are saying, you have no idea what you're talking about. You know, we're seeing this every day, and it's crazy.
I think that, let me ask you this question. It seems to me like we're kind of honing in on one of the problems, which is that there's system-wide decisions that get made, and then there's reality where incredible cost shifting occurs, because if you have to spend, as a trained physician and with your staff, a lot of extra time doing some kind of administrative work rather than taking care of an individual in crisis, it's a bad use of your resource. It's also very inefficient if that individual, to save a month of premiums in Medicaid, instead ends up 4 times at Queens ER and admitted. That costs many thousands of dollars, but it doesn't seem to get captured in the overall cost.
Everything is in a different silo. DHS contracts with a managed care company, who contracts with a pharmacy benefit manager, who contracts with 3 different case manager companies.
Yes.
And each one has their own pot of funding. So if the pharmacy benefit manager is trying to save money on drugs and decides to restrict their formulary, and that patient ends up in the ER, they don't pay for it, the health plan pays for it. And case managers change every other month. Most of them are just checking in once a month to say, how are you doing, but they don't never see the patient.
Yes.
They're accomplishing nothing. All this money is being wasted. It's wasted.
So this takes us back to a couple of your main points. One, that we're spending 31 cents on every dollar for administrative work, which is not care. And 2, that your principles of covering everyone and assuring access and simplification plus reinvesting that administrative savings would be the solution. That would be the model you'd utilize.
Yes, and healthcare is very complex. There are many, many patients with unclear diagnoses, multiple interacting diagnoses, diagnoses that shift over time, whatever. It's not a straightforward thing.
Right.
And the only way you can manage that kind of complexity is to have a well-trained professional who can look at the individual patient situation and try to sort it out. It can't be done from a health plan. They can't possibly deal with that complexity based on administrative policies. So they do a lot of clunky things that waste everyone's time and accomplish nothing. The only one that's capable of managing care cost effectively is a doctor that knows the patient.
Right. This brings me, we have a couple more minutes in this segment. This brings me to a question for you. So one question I've raised with the insurers is they say we need better coordination. And I say, fine, we do need better coordination. And then they say, therefore, we're going to invest in coordination. We're going to pay an outside company. And I'm not trying to single them out for criticism, like Healthways. We're going to spend a lot of money, and people are going to check in and coordinate the care. And then all my doctors say, but I don't know that person. My patient doesn't know that person. It doesn't work because there's not trust. They don't have a continuous relationship. I say, why don't we invest that money directly in the doctor's practices? What would you say to that?
Coordination of care, as I started in private practice here in the 80s, before managed care came in.
Right.
At that time, almost every doctor, including all the psychiatrists, took some Medicaid.
Yes.
It wasn't that hard to find a doctor who would take a Medicaid patient. When there were transitions in care, most doctors would try to write a summary of the relevant information and send it to the receiving doctor and expected to get a phone call, things like that. Coordination of care was actually better before we started mucking around with trying to micromanage healthcare by administrators. And so now they're proposing new layers of administration to try to bring coordination to something that they themselves have mucked up.
Okay, well, I think that's a very elegant way to put it. It's real, and I think we're going to take our break here. We're at a half hour. I'm Josh Green, Healthcare in Hawaii, joined by Dr. Stephen Kemble, a big thinker on healthcare policy and healthcare reform.
Aloha, hello. My name is Hong Jiang, and I host ThinkTech Asia every Tuesday afternoon at 4 p.m. At our show, we talk about issues that are important in Asia, such as environment, culture, history, religion. We broadcast live, and we're also on Olelo 54. Make sure to tune in, and we'll see you there. Thank you. Goodbye.
Aloha. Welcome back to Healthcare in Hawaii. I'm your host, Josh Green, physician from the Big Island, State Senator. I'm joined today by Dr. Stephen Kemble, trained at Harvard, back here in Hawaii, working in the trenches with patients who have mental illness. He's a primary care provider, and he has a lot of big thoughts on what the healthcare system should look like. In our first 30 minutes, we've talked extensively about the Affordable Care Act, some of the challenges we see on the ground, some of the bigger problems we have with administrative burdens, and ways we might fix it. But now I want to pivot to solutions. I want to ask Dr. Kemble, Stephen, if I gave you a magic wand to build the system from the ground up, make it work for the people that haven't had good care, haven't had good access, cost too much, where would you start?
Okay, the first thing I would do is I would put everyone in the same system and make sure that everyone in the state was covered, so that you would not have all different benefit packages, formularies, networks, things like this. Everyone would be in one system.
Okay.
And get a lot of the administrative barriers out of the way.
Got it.
If doctors were paid the same, regardless of whether the money for a particular patient's care came from Medicare, Medicaid, or an employer, if you pooled all that money and paid doctors the same across the board, then the doctor would not discriminate against people based on their insurance status.
Okay.
And they did this in Western Colorado, and they have dramatically better access to care for Medicaid patients and dramatically lower acute care Medicaid costs.
Which I would point out is interesting because since we have so many individuals on Medicaid anyway in the state, 360,000 of our people, to single out a group that we can't take care of or doctors won't see just is not going to work. Okay, so go on.
So you pool Medicaid funding with commercial, and HMSA could do this with Akamai Advantage for Medicare, with their commercial HMSA, and with their Quest plan for Medicaid. Pool the money, pay doctors the same regardless of where it came from.
Okay.
And then you could greatly improve access to care in outpatient settings for Medicaid and actually start keeping them out of the emergency rooms and hospitals.
Okay.
I would pay doctors one of the three ways we talked about: salary, fee for time, or capitation, for just what they do, not for all the costs of care.
And would you do that based on their discipline? Would you have a standard plus or minus for primary care people, for specialists, for super surgeons? How would you do that?
You could do capitation for primary care because you could say everyone needs a primary care doctor, so if every primary care doctor divided up the population and got their share, you could capitate that. For specialist care, not everyone needs a specialist, so you still have to do some kind of fee for service. I just do fee for time for them, or salary if they're working for Kaiser.
Okay.
You could include Kaiser in this by just giving them a global budget and run their delivery system, and they wouldn't need to have an insurance function anymore. They'd just be capitated to.
Well, wouldn't it be complicated because we know how many patients they have, and they know how much their patient population has actually cost. So I think that would be the least of our problems.
They'd be an alternative delivery system. It would work just fine.
Okay.
Then you would have a payment system that eliminated all the complexities of billing and coding. If you're paid for time, you just log the time that you booked for that procedure or patient, or the average book for that procedure in the community. And you can add up the hours to tell if anybody's being unreasonable.
Yes.
Check with their wife to see if they really are spending 20 hours a week in the hospital or whatever.
Right. Okay. Good. Yes. Please.
So you could eliminate a lot of the temptation for fraud and abuse and the opportunities for fraud and abuse by going to an incentive-neutral payment system. So I would do that.
And that can be checked very easily.
Yeah. I also think that if practicing primary care in Ka'u or Kauai was administratively simple, you didn't have to have all these hassles of whether you're going to be stuck with too many Medicaid patients or not, and you got paid the same wherever you did primary care, maybe with a cost of living adjustment because it's more expensive to live on the outer islands, then doctors would voluntarily want to go practice in underserved areas because it's rewarding.
Yes.
I grew up, I did my training in a Medicaid system,
and
I really like working with that population. I love working in Queen Emma Clinic. I can't do it in my private practice because of the administrative burdens.
Right.
But if it were easy, I would open my doors to Medicaid.
And my experience was similar to yours. I've worked in the National Health Corps in a clinic in Ka'u, and It actually was really wonderful. And for me, interestingly, because I was with the community health center, I didn't do any of the administrative work or the paperwork. I just saw patients.
Yeah.
So I had a very different experience. It was challenging, don't get me wrong.
It's challenging but rewarding.
Yes.
Those patients are the most appreciative patients you'll see.
That's right. Okay, so you would keep the community health system together, or you didn't send doctors to go there and work?
I would make it simple enough so a doctor with a medical assistant could do primary care anywhere.
Right.
For those patients with more complex needs, where you need community outreach, I would use the community health centers for those patients. You know, here's where you can get translators. Here's where you can get social workers, pharmacists who can help people sort out their medicines. So the ones who need more help can go to those clinics. For those services that require outreach in the community, like in-home visits for patients who have trouble getting into the clinic, those kind of things, I would have that set up as a community resource based on patient needs. So if you're a doctor trying to take care of a patient and you say this person has been missing their prescriptions because they can't make it to the pharmacy, they're crippled, they've got transportation problems, whatever, we'll send someone out in the home. You call a number, and it's a community resource. You say, I have a patient that needs your services. They would send someone out, work out an individualized treatment plan, and take care of the problem. But don't apply it to everybody across the board. Use it where it's needed and let the doctor who knows the patient decide what's needed where. Okay. And that, I think, would really work much better.
That's very different. Okay, and now what would you do with these incentive programs or these pay-for-quality programs? How would you deconstruct some of that and put that resource into the doctor's world?
I really do believe in quality improvement, but I think it's a big mistake to tie it to money.
Okay.
And actually, Don Berwick, the author of the Triple Aims, called pay-for-performance toxic. He wrote a paper called The Toxicity of Pay-for-Performance.
Yes.
And we're quoting his Triple Aims and doing the opposite of what he said to do.
So what does Berwick say when he sees these programs blossom in different places?
I would have quality improvement projects that are developed locally.
Yes.
That are not centrally controlled measures where you're being paid or punished financially for meeting them, which don't apply to a third of your patients. I would let clinics or units in hospitals develop their own projects to improve care.
Yes.
We talked about an example of prescribing broad-spectrum antibiotics when a narrower spectrum, cheaper antibiotic would be better. It would slow the rate of antibiotic resistance. If you had a way of gathering your data on antibiotic usage, you could check with the local pharmacies and see how many of which you did. And the other ER doctors or the doctors in the hospital where you practice did the same thing. And you got together and said, we want to bring the use of the broad-spectrum antibiotics from 40% down to 15%. And you could track your statistics and see how you did at improving that and do a follow-up. And you could get real improvement in quality with no central administrative expense.
Yes.
The only expense for that is training people how to set up those kind of projects at the local level. So I would do a lot of that, local quality improvement, but not the central administration stuff.
Now, let me play devil's advocate, assuming people would be very busy, they'd be seeing a lot of patients. There's a lot more patients to see than we see right now. The providers filling their days with visits and so on. Would someone argue that they're just not going to do those projects if there's not some reason or some incentive? I've heard that before.
Well, I was involved with Mountain Pacific Quality Health. We were doing quality improvement projects for Medicare for years, and we never had financial incentives tied to those. And we did a pretty good job of meeting our goals in that program. So I believe it can be done, and it's been shown to work. Okay.
So now we've established a new system where you've decreased the administrative barriers. There's one system, so it's simplified, whether it's run by an insurance company as a third-party payer or it's a single-payer system like you've spoken philosophically about before. You pay the same, so we don't discriminate against patients. You pool the extra resources to do things that are meaningful. Then what? How do we get enough doctors and nurses into the system?
Well, I think that if practicing primary care were rewarding and fun again and it weren't a huge headache, that would not be a problem. I do think it would be helpful to have subsidized medical education. At the least, we should do the bill you helped push through last year of repaying medical debts in exchange for serving in underserved areas or underserved specialties. But I think if we actually had government subsidies for medical education, that would mean that you could pay doctors at a somewhat lower rate for the rest of their careers because you wouldn't be covering the cost of their medical debt. And right now, since most healthcare is paid for by the government anyway.
Right.
2/3 of it is paid for by the government anyway.
You mean by Medicaid, Medicare, veterans?
And government employees.
Yes, okay.
You combine all that, it's more than half of the U.S. healthcare dollar. And what government spends in this country is more than any other country spends in total.
Yes.
Including patient share, everything else.
Right.
So, yeah, if you had, where were we?
We're talking about loan repayment or
Oh,
something
yeah,
like that, or some incentive.
Yeah, you could reduce the prices paid, the fees paid to doctors in proportion to the savings they have from not having to cover their medical educational costs, and that would bring down the cost for the whole system for the rest of their careers.
And you get more primary care, which we all know, like in our state right now, only 9 cents of every dollar goes to outpatient primary care. The other 91 cents finds its way somehow into other services. Ironically, we all know that most monies should go into early diagnosis, prevention, vaccinations, whatever you feel will actually improve people's health.
If the government were to pay for medical education, then they could also allocate more resources to training primary care than they do to training subspecialists.
Right.
So you could help with the workforce situation that way too.
So,
but that would be cheaper. I would pay hospitals with global budgets. So they get a global operating budget, and then they see whoever comes in the door and they take care of them the best of their ability within that budget.
yes.
And if we need a new hospital in a rural area or someplace that's underserved, that should be planned centrally. Someone should say, we need a hospital in this area, so we're going to fund that. And there should be a separate budget for capital expenditures based on community needs.
So are you saying you would have a kind of a more vibrant public health sector making some of these decisions?
Yes.
Okay.
You need good public health. You need school nurses again. You need public education on public health. You need dental hygiene. There's a lot of public health things that would really help bring down healthcare costs if it were applied broadly. And that takes it takes the involvement of government to do that.
Right. Yeah, because it's a big, big system. We only have a few minutes left. You have a lot of very, very complex and valuable things to say about healthcare. If I were going to just get the kind of the 2-minute, the 2-minute wisdom from you on what the healthcare system should look like 10 years from now, what would you say to people?
Everyone should be covered. Keep it administratively simple, and use the administrative savings to bring down the prices that you pay. And you design everything around assuring that patients' healthcare needs get met, rather than around the convenience of an insurance company or some other payer. You organize it around efficient, effective care using the input of the caregivers themselves.
And who would you prefer ran such a system?
If you're going to have a universal system, I don't see how you could do it without government being involved. But you could use a third-party administrator to, process claims and fulfill the essential administrative functions. That would be fine with me. But they would be operating more like a public utility than a competing plan. When you have competing plans, each plan's incentive is to try to push the sicker people onto the other guy and to avoid paying for sick people, because too many people have known health risks. So competition really doesn't work in healthcare. You need a universal system, and then you make it as efficient as you can.
And I would add to that before we close that I think people need to realize there just are no shortcuts in healthcare. If you try a shortcut in one area and try to save a few dollars here, you end up getting stomped and squished with large expenditures and worse health somewhere else, whether it's in the ER or in the operating room.
Whack-a-mole or squeezing a balloon or whatever, just pops up somewhere else.
It does.
And usually in a more expensive, uncontrolled form.
Okay. Well, I think that this has been an excellent discussion. I'm so pleased you were able to join me. What I'd like to do is in the years to come to kind of update ourselves on where we are. I see some well-intentioned people give good runs at change, and then often it falls because people just don't quite have the political will to make it work properly. So let's see where this goes, and we'll keep advocating.
It's a long-haul commitment as far as I'm concerned.
Okay. Great to see you. Thank you, Stephen. This is Josh Green with Healthcare in Hawaii. I've been joined by Dr. Stephen Kemble, who's a health thought leader, who also is a psychiatrist trained here and at Harvard. Thank you for joining me. See you soon.